Well, hello everybody, and welcome to this discussion. We've got Dr. Gordon Caldwell here today to talk to us about his experience of whistleblowing. Before we get into the details, I ought to thank Helen Hughes and Lottie Tizard from Patient Safety Learning just for setting this all up and putting Gordon and myself in conversation together. So we'll just be talking about aspects of safeguarding and whistleblowing in the context of healthcare today. So I'd like to just introduce myself. I'm Peter Duffy. I'm an ex-consultant urological surgeon with my own experiences of whistleblowing. But we're not here to talk about my opinions today. We're here to talk to Gordon and try and get his sense of whistleblowing in the NHS, where we're up to and where we might be able to improve. So first of all, Gordon, welcome. Thank you for attending. And can we just start off by perhaps talking generally through your career and maybe then coming on to your specific experiences of NHS culture when it comes to speaking up?
Yeah, thank you, Peter. Yeah, I'm Gordon Caldwell. I'm a retired consultant physician, and my special interests were diabetes and endocrinology, and I also had a lot of experience in use of information technology near to the patient, considerable interest in medical education and training of junior doctors and nurses, and more latterly as well, patient safety. So I started off in medicine in 1974 as a medical student at Oxford, and finished off in 2022 by resigning from the NHS, probably 4 years earlier than I'd intended to, having worked for about 23 years as a consultant in Worthing and 4 years as a consultant in Oban Hospital on the west coast of Scotland. Thank you.
And obviously that's taken you sort of up and down the length of the country, hasn't it? So you must have picked up a good sense of the sort of culture that exists in the NHS when it comes to speaking up and whistleblowing. I mean, what's your opinion of that?
Well, I think you have to have some idea of what we mean by culture. And to me, the best definition I've had is how we do things around here. So simply, what's the atmosphere, the environment? How do people behave to each other? How do they talk to each other, consider each other, take matters in hand? And I think my perception of culture in the NHS changed considerably from 1974 when I started as a medical student to the end of my career in 2022. I think early in my career, and the cultural emphasis came from clinicians, from the doctors and the nurses, who were preoccupied with the correct care of patients, of individual patients. I think the emphasis how do you arrive at the correct diagnosis? Then what's the correct treatment? What complications arise from the disease and from the treatments? Monitoring of iatrogenic harm. By iatrogenic harm, the harm that comes from interacting with medical professionals. We can do the wrong procedure, we can mess the procedure up, we can give the wrong medication. Some of it's inevitable, the complications of medications, but some of it is error and harm. Working on the clinical outcomes of defined groups, I was an endocrinologist. What happens to people who have overactive thyroid gland? How do they come out and how do they do? And there's a lot of respect for science in medicine, respect for clinicians, that we knew how to treat patients. A lot of collegiate activities amongst the consultants, lunch together, educational meetings, mortality and morbidity meetings, professional self-regulation. As a professional, you regulated yourself, and we're regulated by our collegiate behaviour in the colleges, oversight by the Royal Colleges, and team cohesion. Then by the time that the end of my career came round, I think it was very different. In those early days, I don't think we talked about speaking up. We just talked about honesty. If we'd put in a central line and caused a pneumothorax, whilst we put the central line in, that's a recognised complication of the procedure. We admitted to it. We talked about it. And as you know, Peter, over the 30 or 40 years I was in medicine, the techniques for putting in the lines improved, and it's much safer now. But by the end of my career, I think the culture in the NHS, it felt to me as if clinicians and patients were the problems, and that we had to be managed and instructed what to do, and those who didn't comply were to be punished. The culture was to get the number of patients correct, get the numbers through, regardless of the quality. So if you could see 50% more people in your outpatients, that was good. And it didn't matter if the diagnosis was wrong in more
Mm,
patients than it was before.
yes.
So the culture really was to hit the targets. The targets were very simplistic. They were punitive or rewarding financially in one way or the other. So it came that we as clinicians were people who needed to be managed and told what to do and told how to do it. And if we didn't comply, we were in trouble.
Yes. And
Um,
there was a reputational element as well, isn't there, in all of this? Feeding back positive news all the time, and anybody who's not
mm,
doing that is not regarded as an asset, is more of a liability. Is that a fair comment, do you think?
I think so. I mean, particularly that struck me during the changeover to foundation status in
Yes.
the NHS England hospitals, that the executive team all wanted to impress Monitor and CQC and get foundation status. So anything that was seen as counter to being a successful organization on the way to impressing Monitor, then that was seen as something which was, you were seen as somebody who's holding the organization back, I think.
Yes. Yes. And that sort of attitude, I think, has persisted, hasn't it?
I think it has. It's talked about enough that, in a sense, the NHS is the religion of Britain, and that you cannot say anything bad about it, even though the evidence is clearly there that it's not functioning at all well. You're
Yes.
not you're not an ally. You're a heretic if you say that it's not the best health service in the world.
Yes. So do you feel the culture has therefore got worse? Is that oversimplistic?
No, I don't think it's oversimplistic. It's difficult to know, looking back on a long career, how much I just didn't see those things in the first 10 or 12 years. I was, concentrating on learning medicine, passing the exams, getting promoted to a consultant. I wouldn't have
Mhm.
known who ran the hospital, other than the fact that it seemed to be run by the senior doctors and senior nurses, on a clinical basis. So I wouldn't have known who the head manager was in the hospital until I became a consultant, and the Thatcher and Blair reforms came through and put the
Mm.
CEO in charge over the clinicians.
Yes. And you've had your own experience of whistleblowing, haven't you? Just coming on to the sort of specifics. So, can you take us through your experience of blowing the whistle, how it was received, and what sort of an
Mm.
impact it had on you and your family and so on?
I mean, looking back on my career, I can see things which now would be categorized as whistleblowing, and I never thought they were whistleblowing when I was doing them. Um, I was thinking back to when I worked in Worthing Hospital, um, and there was quite a lot of talk about patient safety and quality of care from the Darzi reforms and such like. And one of the founding principles to me of patient safety in a hospital is knowing which consultant the patient is under, so that the nurses can call the correct team when something goes wrong with the patient.
Mhm.
Now, that information about which consultant was in charge of a patient in the sort of safari ward round situations we were in at the beginning of the 2000s, to me meant that the nurses on the wards didn't know which consultant was on charge and couldn't know which was the source of information which gave the definitive answer. So there's the patient administration system, the drug chart, the notes, any number of things where it might be that particular consultant was in charge. And I knew of a patient who was allegedly under my care that I didn't see for 5 days, and on the sixth day died. Um, so I set about doing an annual audit of the various sources of information and proved that it was very unusual for the nurses to be able to be sure which consultant was in charge. And when I raised that with the medical director at that time, he then called me into a meeting with the director of human resources at short notice, told me I didn't need to take anybody with him. It was all fine. I was on take that day, medical admitting.
Mhm.
5 minutes into the meeting, he said that he thought I'd lost my sense of judgment. And by the end of the meeting, said that I had to go to occupational health for a psychiatric assessment. Remarkably,
It's not uncommon, is it, in whistleblower cases?
no,
I've heard that quite frequently, and it's a bit like the old East Germany or
hmm,
the Soviet Union, isn't it? If you don't agree with the state, you must be a bit sort of loose of a few screws, and therefore
yeah.
deserve to be incarcerated in a psychiatric institution or something.
Well, remarkably, although they both thought I'd lost my judgment, they left me in charge of the take. Then after a week, the director of human resources hadn't referred me to occupational health, so I had to show her how to do it. And meanwhile, I'd been to my GP, who thought I was very, very sane. And when I got to occupational health, they said they thought I was one of the most sane characters they'd met, and commented that they thought the medical director was behaving like Stalin.
Yes. Well, there we go. Yes. Yeah. So not well received then.
Could I interject on this one? So, so Gordon, so there was no kind of informal conversation. You've got concerns, share them with me. It was straight into an HR process.
Well, that's the way it felt. Yes. Yeah. I was told it was an informal discussion, and then by that stage, I knew enough about sort of employment law that if your employer said you had to go to occupational health, you didn't have any choice. And I was quite happy to go to occupational health because I was fairly sure that I was sane. And what got me through that, Peter, I think, which perhaps you didn't experience so much in your difficulties, was that the next morning at the end of the post-take ward round, I asked all the junior doctors, did they think I'd behaved as usual? What about my judgment and so on? And they all said, "What are you asking that for?" So I told them, and they said, "Well, that's crazy." And they wrote a letter in support of me, as did all the staff in the diabetes centre, and 2 or 3 of the consultants in the consultant body as well spoke up on my behalf and said this was a nonsense.
That draws out a very important point, doesn't it? Which is the support of your peers in all of this. It's been my experience and that of a good number of other people that if you're isolated as a whistleblower, it's so much easier for you to be picked off. So that's good to hear that you were able to avail yourself of the support of your team there.
Yes, and I think this knowing your colleagues, relating to your colleagues, knowing which ones you think are going to stand up for you and stick with you. And I think particularly I'd invested a lot of effort in the training of junior doctors on the post-take medical ward rounds, and a lot of effort into the diabetes centre as well. So those people knew my character and knew what I'd done and what I'd achieved. And so if I'd just been completely isolated, I mean, that it probably could have finished me off.
Yes. But this wasn't your only episode of whistleblowing, was it? Am I right in thinking there was a more recent one as well, which perhaps had more of an impact on you and your family?
Yes. Again, I'd never really thought of this as whistleblowing. Oban Hospital is a very small hospital. It's only got 4 medical consultants and 3 consultant surgeons, 3 anaesthetists. Very small hospital. And after about 18 months, I became clinical lead just before the coronavirus pandemic came. And after the pandemic began to settle down, the pressure was all there immediately. How are you going to hit the outpatient targets? What are you doing about supervision and training of junior doctors? How are you going to catch up, with all the backlog of waiting list stuff? And to me, there was a big issue with that 4 consultants was inadequate to provide safe care for the amount of work that was required. And the answer just seemed to be that we were rather lazy, inefficient consultants, and that we just ought to work harder. And the supervision of the junior doctors at night, there's no medical registrar. So it's direct from the junior doctor, a foundation year 2 or GP trainee, to the consultant.
Yeah.
But there were advanced nurse practitioners in the hospital who the health board was claiming could supervise junior doctors. And according to the RCN standards, these people, most of them were not advanced nurse practitioners. They didn't have master's degrees, they didn't have prescribing, they didn't have clinical examination. And yet they're saying that these were safe to supervise the junior doctors at night and to supervise their training. And however much I tried to put this to the health board and to my management team, they just would not accept. And there was some very simple maths there, Peter. If you want to provide 42 clinical sessions of a week, you have to have people, about 5 consultants at least, to do that.
Yes.
And if you haven't, you can't do it. And they would not accept these. And eventually we just got to a stage where consultants were leaving. We were going to have lots of locums, which made it even worse and dangerous. They wouldn't accept my argument or my case, and it got so stressful that I simply couldn't go to work any longer.
Right.
And then after that, it was then I realised, well, there are these whistleblowing procedures. In Scotland, it's different who you whistleblow to. So I went to NHS Education Scotland because I thought it was dangerous the way the junior doctors were not being supervised. And they validated all my points. In fact, more than validated all my points. It was one of the worst educational training reports I'd ever seen. And I'd been in medical education for 15 or 20 years by that time. And sufficiently bad that they then notified NHS Healthcare Improvement Scotland, which is sort of the equivalent of CQC, but doesn't seem to have the same legal teeth as the CQC. And again, they validated all the points I'd raised, and then accepted written responses from the Highland Health Board saying, changes have been made, lessons learned, improvement made, and signed it off as satisfactory. By which point they'd lost all 4 consultant physicians from Oban Hospital and 3 consultant physicians from Fort William Hospital, all over the same issue that there's not enough staff to do the work.
Right. So I was going to ask what sort of support you got from your colleagues, but I think you've just answered that, haven't you? They clearly was just as concerned as you were.
Yes. I mean, we had one of the other consultants held on for another 18 months or so, but eventually left. Another consultant retired prematurely. I'm not sure exactly the circumstances, but again, I'd expected him to work for another 5 years. And then we had a long-term locum junior consultant who we hoped would be, foundation for the future of the hospital, left as well. And in Fort William, again, tragically, 2 or 3 excellent consultants left. So, I didn't think of that particularly well. Obviously, at the end there, I thought it was whistleblowing, but most of the time, I just thought, well, that's my job. I'm a clinical lead. I can see that we're not providing the right care. I can see we can't do it. And with the clinical lead in Fort William, we actually had some very imaginative and good ideas about how, at relatively low cost, we could secure and retain staff into the future. But those were sort of written off as there's no money. And as soon as we resigned and left, they started employing agency locums.
Yes,
costing them an absolute fortune.
Yes, yes.
I think the last night I was on call, I worked out I was being paid less than £5 an hour before tax, and then there's no money. And the next week there was a local consultant agency locum in there doing the same for £100 an hour.
Yes. Yes, that all sounds very familiar. And you were saying you ended up going off sick with stress. I mean, was there a particular event that led to that? I mean, what was it that?
Well, it was
in the end,
one of the consultants the consultant who retired prematurely. I could see that it was coming up to December time, I think. We'd be left with one consultant on the wards and some agency locum consultant staff to run the service, and it wasn't going to work.
No.
And that you couldn't even bring in the locums who were coming in were saying they were overworked and it was an impossible workload and they'd never work in the hospital again. So the service was going to fall apart on whatever it was, the 1st of December or the 1st of January. And the answer just seemed to be, oh, you've got to be more imaginative. You've got to find other ways of dealing with the work, rather than facing the reality that you needed more consultants, needed more staff, and you needed a dramatic improvement in the way the work was organized and run.
And these sort of stresses and pressures on you, I mean, how did this work out for your family?
Well, it got to the stage where my wife said, you didn't sleep last night. You're doing all these calculations about numbers of sessions and numbers of consultants. You can't possibly be safe to drive in November in the dark an hour down to Oban. She said, I'm going to lie down in front of the car and stop me driving to work. So fortunately, I listened and thought that was sensible advice, and actually never went back to work after that.
Right. And so what has happened at Oban? Just thinking about patient safety side of things now. I mean, what is the current situation? Has it been addressed, or is it still a problem?
It's still a problem because it's difficult to keep up with what's going on there now because I don't have the contacts. But I
Yeah.
think they may have appointed one permanent consultant physician, a doctor who'd been doing the locums on and off for a while. But to me, if you're running a hospital with 4 consultant physicians, you need at least 2 permanent consultants there to hold it together, to supervise the juniors properly, see them through their training, and to make sure that the locums themselves who come in are up to scratch.
Mm.
So I'm not quite sure how the junior doctors there get approval for their training when there aren't permanent consultants. And I don't know the exact situation with the ANPs, but from the situation they're in, if, as the board claims they're now fully qualified, I don't see how that was done within the time frame.
Right. I mean, this
Can
all
I,
sounds.
can I ask?
Yes, sorry.
Yeah, can
Helen.
I ask a question about when you say the board, Gordon? You know, were these because an area that interests me is the extent to which a full board, both execs and non-execs, understand these issues. Was it a small number of people, or was it, you know, something of such significance about the safe running of the hospital that you were highlighting, or you and your colleagues were highlighting? Was this something that was the full board's, consideration of getting expert advice in? You know, that there's always opportunities to get Royal Colleges in to do invited reviews. How visible an issue was this?
Well,
How seriously did they take it?
I think some of this is probably just to do with my use of the word board, because I think in Scotland, a health board is the organisation that runs the health provision in a particular area, rather than meaning the board of that
Okay.
organisation.
Right.
So I don't know what the similar would be in England. On the south of England now, Brighton, Worthing and Chichester are all one big hospital group. That would be what you might call a board in Scotland.
I suppose the reason I was asking was the visibility of that issue by those senior leaders within the organisation. So was this something that their formal board of executives and non-executives were being informed about and were taking a view on? Or
I'm sure they were, because there's a hospital in Caithness in Wick, similar size to Oban, which had run into almost identical problems with retention of consultant staff, numbers of consultant staff, supervision of junior doctors. And the NHS Highlanders spent a large amount of money, which they'd never disclosed to me, to resolve the problem by employing rural emergency practitioners and getting consultants from Inverness to go up to Caithness and so on. So it was, the cards were on the table. Oban was exactly the same. There were some confusing issues in that Oban Hospital is actually within Argyll and Bute Health and Social Care Partnership, and how that relates to NHS Highlanders is a mystery. But NHS Highland is ultimately responsible for Argyll and Bute Health and Social Care Partnership. So yes, I'm sure they knew they certainly knew right up to the top level, because the chief executive at the time had issued at my request an organisational map to clarify how Oban Hospital fitted in, but unfortunately the map that was issued missed Argyll and Bute off completely and Oban Hospital off completely.
And so coming back to patient safety, I mean, this sounds like an absolute car crash, quite honestly, because they essentially lost all of their experienced, committed consultants and then ended up paying a vast amount more for locum staff who, no matter how good they are, simply don't know the local system. They come in, they don't know the patients. So it really sounds like an absolute disaster. I mean, what do you think it was that drove the individuals in charge to take such a risk and not to back off and try and resolve the situation? What was driving this?
I really don't know. We speculate, was it a conspiracy? Was it a plan? Has it always been the Scottish government's plan in recent years to close down the rural general hospitals, concentrate everything on Inverness, provide some accident and emergency departments staffed by paramedics in the localities and do all the big stuff in the center. I mean, that would, if that's what they're planning to do, then they'll achieve it the way they've gone about it. If it wasn't what they're planning to do, that's very likely what they'll end up with as well, because they seemed very unimaginative to me about how you could possibly try to attract senior staff, how you could support the staff that you have already. And it's very odd because the NHS Highlands, the Highlands and Islands was actually where the NHS started back long before the 1940s. There was a health service in the Highlands and Islands, which was the NHS embryonically.
Right.
And there's a general practitioner in Ballachulish, where I live, who drove a lot of this, Dr. Lachlan Grunt. And
Right.
he said, if you want to provide, the people in the Highlands and Islands should get the best healthcare, or at least as good healthcare as everywhere else. To do that, you're going to have to attract the best people. You're going to have to treat them well, and it's going to cost you a lot. And you're going to have to make sure they can get away for their continuing professional development because they're rural and isolated. And Highland, to me, that's what Highland should have been arguing to the Scottish government. But they seem to have just taken the Scottish government, there's no money, there's nothing you can do about it. And, oh, well, there we are, we'll just put up with it.
Yes. And in terms of learning from this, if you were able to rewind the clock and go back to where you were before all this car crash started to happen, what would you do differently?
I think it is very difficult in the current NHS culture, as we call it, because so much of it depends on getting people, like-minded people, together and to talk together and to then to be able to speak with a united voice. And actually, Open Hospital was really nice because we did have lunch. So you had a chance to talk to people. But when I was at Worthing Hospital, the last 15 or 20 years, never had lunch. And
Yes.
the lunchtime meetings, the educational stuff, the mortality and morbidity had all fallen apart. So the consultants never met together
Yes.
to speak
Yes.
together, even to agree or disagree.
Yes, I
Which
recognise
left
that.
everything in the hands of the director, the leaders of the clinical directors. Just as an aside, I mean, I think the whole Let Be situation might not have got so out of control if that hospital had still had grand rounds mortality and morbidity meetings, because then the paediatricians would have had backing from the other consultants. So it went back to that earlier point, Peter. You can't do it alone. You've got to have colleagues. Yes, you've got to be willing to speak out, put your head above the parapet, take all the flack. But you must have other people backing you who you know you can rely on, who will speak up at the appropriate moment, back you up at the appropriate moment.
Yes. And that sort of leads on to the next point I was going to make is, we've talked about whether you could have done things differently. It sounds as though you probably couldn't. But for other people who find themselves in this kind of situation, what sort of advice would you give them? So as you've just said, try and take as many people with you as you can. You're much less vulnerable if you're in a group. Is there any other advice you would give them?
Well, certainly, I think look to the younger generation as well. I still think that people go into medicine with a societal attitude, a professional attitude, wanting to come in and make a difference. So speak a lot with your junior staff as well, and back them up. So it is very much the same stuff. I think another thought I have is that the more you can get some numbers around things, that's something managers understand. They know everybody comes in and moans to them. But if you can get some numbers, that changes a moan into a fact. And they don't need to be, hugely scientific numbers with big p-values and things like that. In Worthing, we had some problems with X-rays being reported that showed possible lung cancers, but nobody ever saw the report. So by the time the patient presented, they may have come in with a myocardial infarction, had a chest X-ray incidentally, nobody ever saw the report. Then they came in with another condition, by which time the lung cancer was inoperable. So our respiratory physicians had a list of those sort of numbers turning up in their clinics with inoperable cancer where it had been shown previously on a chest x-ray, and I had 1 or 2 patients as well. So we raised our concerns about that. And I think the reason that that was successful was because it wasn't just the respiratory physicians, I was backing them up. It wasn't just me, they were backing me up. And we had numbers. We could say whatever it was. There were 6 or 8 patients over 2 years who might have had a successful treatment for their lung cancer that we missed because of that.
Yes.
Then the radiology department introduced what they called a red flag system, which meant that if that showed up, then the radiology department actually had to make sure that somebody was alerted to make sure that the report was read and acted on.
Yes.
So
okay,
it showed.
That's a nice example of a positive outcome from safeguarding and speaking out, isn't it? Good. Yeah. Well, it's nice to hear something positive because so often.
Just to reinforce that, Peter and Gordon. I mean, because it also reinforces what you're saying, Gordon, about the collaboration between clinicians. That you're not working just in single specialties. You've actually got this collegiate relationship and wider communication, so that you're able to identify and then work together on it. And I do get a sense, and I'm not clinical, and so I don't have that direct experience. But the separation of activities into separate specialties and clinical directorates that are isolated from each other, you introduce a greater risk of this information flows not being in the best interest of patient safety. Would you agree?
Yes, yeah. I mean, I keep on coming back to this, that it was obvious in the 80s and 90s that a whole lot of what kept the organization going well was lunch. Simply having time, which wasn't looking at emails, wasn't looking at your mobile phone. You were with other colleagues. Yes, some of the talk was about what you did in your spare time, and the chief executive kept sheep and somebody else played golf, but the majority of it was all about patient care and about how the hospital was organized and just knowing each other. And we've lost that collegiate feel.
Yes.
And which is then we've lost that collegiate voice. If you want to destroy a profession, set them impossible targets, overwork them, and don't give them a chance to speak to each other.
Yep. Yes.
And if it's not what you want to do and you do those things, you'll still destroy it.
Yes. Well, we're talking here about sort of speaking up and safeguarding and so-called whistleblowing. So I was going to ask you, I mean, do you think that's a terribly helpful phrase, whistleblower, or should we be using something else? Because certainly for me, it always conjures up an image of some sort of fat, red-faced Victorian policeman blowing his whistle saying, "Stop thief," or alternatively, things like, the big international cases like Julian Assange and Ed Snowden and so on. Which aren't really applicable to people like us. And so do you think we tend to get stereotyped if we're labeled as whistleblowers? Do you think there's a better phrase we could use?
I don't particularly like the term whistleblower myself. And I think it goes back to something I said earlier, which is honesty. And a core value of any profession is honesty. And so people must be allowed to be honest and to give an honest opinion. And even when you look at Belbin's groups and teams and things, you've got to have somebody who challenges, somebody who's a bit dubious, somebody who's a bit radical, somebody who's you can never persuade, and people who just have odd, crazy ideas. So you've got to tolerate all those behaviors, and it's the job of the team leader to manage all that and to work out when you're going to press ahead despite the fact that the cynic has said it will never work, and when you're going to listen and such like. So somehow to recreate that behavior, really, where that's how you run the organization, is that you tolerate differences of opinion, you listen to people, and at the end of the day, somebody's got to make the difficult decision as to the way ahead. But I think it's become far too much controlled centrally by government. These are the targets. This is what you'll work to. This is what you'll get rewarded for. This is what you get punished for. And then it's not a manager's job to question those things, edicts set by government. It's the manager's job to do it. So you'll have seen it as well, Peter. When the 4-hour target came in, we used to have managers arriving at 3 hours 58 minutes, insisting that you moved the patient. You say, well,
Yes.
we still don't know what's wrong with them. We don't know which is the best department for them to go to. They've got to stay here. And they say, oh no, you can only have 10% of your patients where that's the problem. And you've already had your 10%. You must move them off to the ward. Now that manager's doing what they've been told to do. And they've been told to do it by government, who said, these are the targets, not indicators. These are the targets. And you'll either get punished or rewarded for it. So I think that the change that we need has to come right from the top. We're in the middle of a build up to an election.
Yes.
And the behavior of our politicians is appalling. They think this is the way to run a complex modern organization, is to shout at each other, denigrate each other, bully each other, undermine each other.
Yes.
And if you're setting that at the top, it's no surprise it goes up wrong at the bottom of a public service.
And that leads quite nicely on to what I was going to ask next, which is how can we try and make the system safer for both patients and also for whistleblowers?
Well, it's such a complex issue, and I think as well, in my opinion, we've got decades where we've been going wrong, so it's not going to be easy to turn it round. I think the cultural change that came from Thatcher and Blair was poor for healthcare. It may be the way to run a big business organization, might be the way to run Amazon, but it's not the way to run healthcare. And so now we've got at least one, if not two generations of people who manage healthcare who thinks that's the way to do it. So to undo that is really difficult. And I find it disappointing that most of the political parties are still talking about targets and numbers in waiting lists and such like, rather than what I'd call quality indicators. So it's an indicator of how well A&E is operating, how many people are getting out in 4 hours, but you're not going to get penalized one way or the other. And that might be offset by the fact that you're getting to see people in outpatients and urgent outpatients in 2 days. So it is very complex. And I think the way to unravel it is to distance the NHS a bit from politics, and to also to get anybody who's trying to run the NHS to read the book Intelligent Kindness, Reforming the Culture of Healthcare, which really goes through why target-driven healthcare doesn't work, and come back to the professional values. What you would be concerned about, Peter, was what were the complications in your operations? Were you a real outlier compared with other urologists? Were more of my patients dying prematurely than I'd expect? It's the professionalism that would drive us. So take away this big emphasis on monetary rewards. Listen to the frontline staff who really want to look after patients and look after them well, and try and help them. I thought Wes Streeting's approach of going out and saying, tell us all the things that really piss you off in healthcare and get in the way if you're doing your job. Well, there's a great opportunity. If he could really do the things, listen to people and get rid of those things, we'd have so much more time to spend with patients, so much more time to organize and do our work properly, that we might reach that place. But how we do that, I don't know. On a small level in my team, I used to think that I had to culture the culture. So I used to do what are called post-take ward rounds, Helen, which is where 20 or 30 medical patients had come in with heart attacks, strokes, pneumonia, urine infections, whatever it was. And the next morning had to go around and sort them all out and make sure that they were on the right track, and they went referred on to the appropriate consultants. Now, after the middle of the 2000s, I never knew who was going to be on my team for that morning. And the doctors I'd never met before with all these shift systems. So I'd sit them down, do proper introductions, find out who they were, then I'd say we're about to do a really important bit of work for these 30 patients. We've got to get the correct diagnosis, the correct treatment. We've got to get them to the correct care team. And during all that, we've got to learn how to work better ourselves. So it's important that if you see anything that causes you concern or any errors, you'll speak up and point them out. And to emphasize how important it is, you will sign in to my ward round. And they actually had to sign in as the medical registrar, Dr. So-and-so. And it worked, because they would say to me, Dr. Caldwell, I think before you say the next thing, you ought to look at this ECG. And I'd be about to send the patient home, and the ECG would show anterior myocardial infarction.
Right.
Yeah. So there are things we can do on a personal level, which is to encourage within our own teams, within our own group. But I used to say to if we had medical students who were saying, point out if I've missed something out, say, when you move to the next team, be really careful, because it might not be a nice consultant like Mr. Duffy. It'll be somebody who says, "What you dare speak up?"
Essentially.
Yeah.
Yes.
Can I follow up? You mentioned about the post-take ward rounds. You mentioned earlier in the interview about grand rounds and M&M reviews, and they've gone. I mean, has that been a deliberate policy, or is it just sort of they've just drifted out of favour? I mean, we've had Dr. Annabelle Bentley writes often for us on the Patient Safety Learnings Hub, and she's written a blog about what happened to grand rounds. Why have they disappeared? I mean, what's your thinking about that? Why have they seemed to have gone out of favour? Is that deliberate, or?
I don't know. Again, you can speculate on motives. I think my observation was that staff became so busy because we're constantly being driven to do stuff. So if you're a junior doctor, you had to type the discharge summary before 2 o'clock, but the grand round was at 1 o'clock. And if you're a consultant, you'd had 4 extra patients squeezed into your clinic, which was meant to finish at 1 o'clock. So it didn't finish till 2, and the next clinic started. But also, I mean, there is a bit about, I think, clinical leadership in the NHS. I had one medical director at Worthing Hospital, Mike Reimer, who we started grand rounds up again. I called them the curious clinician and tried to make them multidisciplinary. And Mike, as medical director, made that his top priority in the week to come to that. So then the message was, I'm the medical director, I'm directing medicine. I'm directing clinical care in this hospital. The next medical director who came along never showed up. So the message was clear, it doesn't matter. And doctors and most healthcare clinicians really curious. You might be a urologist, but you're still interested in brain surgery and dementia and myeloma and so on. We love hearing from other people about the stuff they're doing and how they're doing it. So I don't think it was deliberate, Helen. But when I used to speak to colleagues in North America, they could not believe we didn't have grand rounds, M&M, and journal club. How can you be a doctor without sharing your cases, studying what's gone wrong or may have gone wrong, and learning the new stuff? Medicine in this country now seems to be, are you following the nice guidelines? Not, have you read the recent papers? Have you read the textbooks? Have you discussed it with your colleagues?
Yes. Well, that's been absolutely fascinating, Gordon. Thank you so much. Helen, do you have any other questions at all?
I have a bit of an off-the-wall question, which may lengthen the interview or not, which is about the role of the media and I know, having talked to you, Peter, and read your books, just the sense of how some of these discussions and debates play out publicly, with kind of within local communities, or whether you get a supportive journalist that will help make your case. What's your sense, Gordon? And Peter, you might want to answer some of this as well. Have individual journalists or local communities and their voices have been informed by what you've done, Gordon, or had a voice in raising these issues? And what would you think that ideally should be?
Well, think I must be coming across as a boring old man. I mean, I think the media has changed since the 1960s, 1970s. You remember the Sunday Times ran the thalidomide story for years. They stuck to it years and years and years until they got through and it came through. And it's unusual now to find a media outlet or a journalist who wants anything other than the next story, and who will stick with something. And I don't think I ever found during my time a journalist or a media outlet who'd really stick with things. Computer Weekly were quite good with MP Fit. I worked with them for a long time, and they were supportive and interested and stuck with the stories about MP Fit, and we're always interested to hear how bad it was. But in Oban area, west coast of Scotland, there used to be the West Highland Free Press, which in the 70s and 80s would have stuck with stories like this week in, week out, whereas the lack of consultants in this area and the lack of a new hospital in Fort William, it will appear every now and then, but it's not a prolonged campaign. Again, I suspect you probably need to be a pretty well-founded group. The College of Emergency Medicine seem to do well these days with influencing the media and getting the stories out. But as an individual, to trap a journalist and get them to stick with you for a long time is pretty difficult, I think.
Yes.
Interesting you mentioned Computer Weekly, because obviously they've similarly been very tenacious with the Post Office inquiry and the Horizon inquiry, and a name check for Nick Wallace, who I think is an amazing journalist who has followed that story for many years, and Private Eye. But as you say, there are comparatively few as they were, because I'm not that much younger than you, if at all. Comparing back to the investigative reports of the Sunday Times in the 60s and 70s. Yeah, I don't know if you want to comment on that specifically, Peter, because of your experience with journalists and the media more broadly.
Yes, I have found the media actually to be very helpful and very supportive. So when my journey started off, I was warned off the media, but in fact, it's the media and local politicians who actually have made the biggest difference for me. And so I just wish we could see more and better quality investigative journalism. And let's hope that things like the Post Office scandal will persuade the quality broadsheets to go back to doing what they used to do best, which is digging into these stories and, if necessary, spending months or even years getting to the bottom of these sort of appalling behaviours and risks to the public.
But I think it must be distressing for our young doctors now coming into medicine to hear us talking like this, and for me it's very distressing to see what's happened to them as young professionals and the way they're treated within the NHS. So I don't know what we can do, Peter, to give them some hope. I think I tended, as perhaps you picked up on a little earlier, you tend to forget the failures and the things that went wrong. I mean, tend to forget the things that worked and went well, and the changes that happened, and that sometimes you can make a difference, and it is possible to change people's minds. But the state that they've got our junior doctors into now, it's almost inhumane the way they're treated. And if you treat your staff like that, how can they care for the patients? Maybe that's me whistleblowing again.
I take your point. And it is important that we don't put people off the career. I mean, I would do medicine again like a shot if I could go back to my teens and early 20s. I still think it's a fantastic career, and I don't want to put people off, but I do want people to be realistic, and I do want to see change. And I think we're only going to get change by talking about it like this, and by involving the media and politicians and so on. And hopefully, it's too late for you and me, but for the next generation that are coming up, we can hopefully make things rather better for them, can't we?
Yeah, you asked about advice and so on. I think persistence is really important. Helen and I talked about working on those post-take ward rounds. Well, I think I introduced something that I thought was helping patient safety, which was a checklist process run by the medical students or the junior doctors to make sure we'd done everything for the patients. Did they have a catheter in? If they did, should we take it out, or whatever? And then I got about 50 or 60 people from outside medicine or outside the hospital to come on those ward rounds, and using that to then gain influence with the King's Fund, the Institute for Healthcare Improvement in America, and to get publishing about patient safety. So I think we have to teach, get lots of friends, lots of allies, know who you can trust, and be ready to persevere and keep at it, and try to remember the things that worked and were good, and know that it will be hard. It's always going to be hard, and there's always going to be people who try and fight against you when you've got good ideas and ideas that should work, or genuine concerns that should be addressed. It's always going to be hard, but as Peter says, it can be a great career, and if we can get that balance again, then we can have clinicians fulfilled looking after patients in a better environment and a better process.
Yeah. Well, that's a good positive note to end on, isn't it? So thank you so much, Gordon. That's been really helpful. Thank you, Helen and Lottie, for bringing us all together. And I guess we'll look forward to the next instalment.